So in your opinion, if we want to improve service delivery and health outcomes, what needs to be done and what evidence gaps do we need to fill?
The main challenge that we have in Kenya is high levels of food insecurity in urban poor settings. For example, in Nairobi, a lot of households are food insecure. For example, some work we did previously indicated that close to 80% of households are actually food insecure. There is also high levels of environmental pollution and poor water and sanitation services. All this combined lead to high levels of malnutrition, particularly amongst children under 5. For example, some work we have done at APHRC has indicated that close to half of children aged less than 5 years are actually stunted. The opportunities for policy intervention include support for the community to be able to be self-sustaining with regards to food production or food procurement.
So the first challenge that I see very critical are one, lack of information about the facilities and the services for maternity health, for maternal health, especially for the young mothers. The lack of information among the population. The next challenge that I see that is common is the issue of unemployment. Employment is very high, and when we're looking at the maternal, the young mothers, we see that many of them are unemployed. And related to that is that when they even get a job, their incomes are very low. Because of low incomes, they cannot be able to then afford the luxury to take care of their children, providing them with the right time, okay, and the right amount of food and nutrition. And then the fourth thing that I'd like to mention is the issue of nutrition. And this really speaks and related to the issue of income. The incomes are very low. They can't afford a balanced diet.
One of the most important things that we need to bring into consideration or perspective is a tool of quality improvement that is called the root cause analysis. This tool enables us to appreciate the real-time specific gaps that need to be addressed, and therefore we tailor interventions that are evidence-based. The second thing that we do to help us know what kind of gaps we have is a client or a community dialogue. And these usually help us to be specific and tailored target interventions to the respective communities based on their culture, their social demographic characteristics. And this therefore enables us to avoid wastage of a lot of health resources. The third thing that we do or we need to do is what we call data-driven programming. This in its essence supports us to do what we call the micro mapping and also the micro planning. And this helps us to have age-specific interventions, so for example, of adolescents, but also it helps us to identify the subpopulations, for example, the first-time mothers that need to receive a service. So as we do this, we have seen improvements, for example, in family health and family planning, that we have the mother takes it up to control the timing and the number of pregnancies during her lifetime. The other arm that we need to leverage on in order for us to improve our service delivery and impact, and where we think we should be able to tap on, is the area of collaboration or synergy with partners. Particularly for us, we termed it as the 3 C's. So we need to collaborate more, we need to improve on the coverage, we need to be able to coordinate better. And this is particularly with the non-health partners, for example, those that handle the livelihood, education, and gender, in order for us to be able to have an impact and a successful service delivery.
So most of these urban areas, they have so many tribes, and different tribes have different cultural beliefs. They have misconceptions and different myths. So as we plan, we have to make sure we incorporate all the myths and misconceptions from different tribes so that we are able to address them. Otherwise, it's not that one case or one item will fit all of them. Also in Uganda, we have quite many religions, and different religions, they believe in different aspects. So as we provide the maternal and child health services, as we plan, as we implement, we have to tackle them, or we have to approach them depending on their belief. Otherwise, if we design one package, it may not fit to all the religious sects.
A key opportunity in person-centered maternity care in the last few years has been the development and validation of quantitative tools to measure it. Research based on these tools have highlighted gaps in women's experiences during childbirth, noting disrespect and abuse of women, poor communication, lack of respect for their autonomy, neglect, and lack of continuous support during childbirth. This work has also highlighted that the care women receive is influenced by factors such as their socioeconomic status, their age, ethnicity, and even the type of facility they give birth in. Now we need to go beyond measurement to identifying effective ways to improve person-centered maternity care, as well as eliminating the associated disparities. Providing person-centered maternity care will involve interventions at all levels of the health system. Providers must be trained to know what it is, understand its importance, and how to provide it. Training must also enable providers to be aware of their biases that contribute to differential care and know how to curb the effect of those biases. And providers must be motivated to provide care in a way that is person-centered. This should include helping them to address the stresses they constantly have to deal with.
The first group of challenge is unsatisfactory respective care reflections on leadership and governance. And here, there are gap in availability of sufficient policy guidelines that guide respective care and mainstreaming and integration in healthy manager routine practice. But also there is insufficient evidence on capacity building strategies for health managers at regional, council, facility level, and respective maternity care. And the opportunity that we see to address this challenge at this group, the government of Tanzania has set some policies emphasizing the reproductive, maternal, and newborn child adolescent health service to be client-centered. However, for these to have full impact, they need to be sensitized at pre-service training and facility level. But also, there is inadequate emphasis on male engagement in some component of reproductive, maternal, newborn, child, adolescent health. The concentration is on syphilis and HIV tests. They are less involved in family planning and natal care services, immunization, postnatal, as well as labor and delivery. But also the other opportunity, the government of Tanzania has initiated multiple innovations, interventions, and efforts to start addressing respective care with other organizations, such as piloting birth companionship intervention in public health setting.
RMC policies and strategy exist and part of integrated reproductive, maternal, and newborn child health policy. But there remains a challenge. One, the newborn and the child respective care, there is very little that is known about it or is mentioned in the policy document. And even if it is mentioned, very little is happening to ensure that newborns and children experience positive experience of care during hospitalization. Policy implementation gaps also exist in terms of lack of responsiveness and lack of accountability at all levels. Either people are not committed enough,
or are not, broad enough to hold people that are responsible when for respective maternity care. Also, they are shifting donor and government priorities, and this may be attributed to civil unrest, for example, post-election violence and epidemics, and mainly this impact very negatively to maternal and newborn health care services.
One of the greatest lessons that we've learned through this implementation is two things. One is our key resource is the healthcare provider, and respecting the healthcare provider, providing an enabling environment so that they can be capacitated to provide the care that is required of them is a critical part of what we need to do to ensure that our clients and our women get the right care through these service providers. And here again, the role of managers has been critical. I think that has been a great learning. And what is truly, a great learning for me is the fact that the language of respectful maternity care is no longer like a non-issue. And here, very quick compliments to all the organizations, especially USAID and WHO, that have taken something that was really, really hard to sell in the beginning and have made it quite integrated and mainstreamed it in an amazing way. And we're beginning to see the fruits of that. So I especially really do like the fact that the definition of quality that integrates the experience of care right into the competency framework. And that has been really valuable even for us implementers in broadening and ensuring that the definition of the care that we provide is holistic, and that women are not just satisfied with surviving childbirth and and maybe avoiding a disability like fistula, but they have the full right to expect and deserve a good birth experience, which ensures that they are treated kindly and compassionately right through pregnancy and right through the childbirth and the postnatal period.
So if you look at Uganda, the average Ugandan woman on average has 7 to 8 children. And it's not really a matter of choice, but I think it's to do with the access to reproductive health services. So I think at a strategic level, that's one area of intervention. But also I think we need to invest in more infrastructure. And we're beginning to see that. We're beginning to see investment in district level hospitals as well as regional referral hospitals and then the national referral hospitals. But I think more can be done in terms of investment in infrastructure that can meet the surge in the population. I think the other aspects that could improve service delivery and urban health outcomes, in my view, is empowering the population to demand. We do a lot of things on the supply side of the healthcare system, but my considered view is that on the demand side, we need to create demand so that our political leaders, our elected officials in local governments, including the municipalities in Uganda, feel the pressure to deliver. So for me, I see that accountability to society as a very important investment that we are still along.